Okay, so actually some of my slides, I saw a few of them from Anita and Wendy, but I'll be quick. But just a little history lesson. So actually the mitral valve was described back in 1555, and essentially he compared it to a bishop's mitre or mitre, and unfortunately it's not that simple, as we've learned. Anita had showed this slide before, but we know that mitral valve disease is very prevalent in our society. And I'm just going to show you a case just to start off. This is an 82-year-old lady who presented with dyspnea, and she had severe MR, NYHA class 3 symptoms, prior CABG, EF of 35%, moderate to severe TR, chronic kidney disease. Her PROM score was around 9%. She was on maximal medical therapy. And so she had evidence of functional severe MR. And I guess the question I have for the group is, again, what would be your options for this lady? Surgery with an isolated tissue MVR, or would you offer MVR plus tricuspid annuloplasty, evaluation for a clip, evaluation for transcatheter mitral valve replacement, medicines, CRT? So there's lots of potential options here. Obviously, the riskiest being surgery and the less riskiest being medicines and a clip, but of course you have to think about efficacy. Anita showed this slide. We know that it's a muscle problem, but on the other hand, patients with low EF and severe MR do worse than patients with less severe MR, and this has been documented in both the ischemic and non-ischemic groups. So when do we surgically intervene on mitral regurgitation? Well, it's thought to be potentially related to symptoms and really related to their LV function and dimensions. And that's the mantra. The question is also whether this patient or any patients will be better candidates for repair versus replacement, and sometimes we'll go forward with a repair if the patient is at low risk. So, like I said, there's lots of potential options for our patients nowadays: pharmacotherapy, surgical therapies, CRT, percutaneous repair, CABG. Don't forget about CABG, of course, for ischemic MR, and transcatheter mitral valve replacement is maybe coming our way soon. In terms of the guidelines, well, I mean, if we're looking at patients with predominantly functional MR, which is essentially what we're dealing with most of the time with a lot of our referrals, I would say, nowadays, essentially they're saying patients with symptomatic severe MR and persistent NYHA class symptoms should have surgery. Of course, you're going to consider other therapies. If they're asymptomatic with severe MR, well, we're going to just watch them. Now, of course, a lot of our patients are asymptomatic, so it's very difficult to assess these patients because they're not doing much, right? Unfortunately, they're not very active, right? So the question is, another question for us is, how should we properly assess these patients in the future? Our surgeons have essentially looked at repair versus replacement, and they've answered some questions for us in terms of, if one is better versus the other. And that was back in 2014, and they essentially showed no difference if patients underwent repair or replacement in terms of their 1-year outcomes, both in death and composite cardiac endpoint. What they did find, though, was that the rate of moderate or severe recurrence of MR at 12 months was higher in the repair group than in the replacement group. So obviously, more experienced surgical centers will have less issues with recurrence of MR. But of course, I understand in the U.S. there aren't a lot of places that are doing repair, so they only do a few a year. So it is an issue, and so a lot of patients undergo replacement now because of this data. So how do we typically treat functional MR? Well, typically we treat it with conservative management. You can see here as your EF is 20 to 30% or 30 to 40%, most patients are treated conservatively. So when do we operate? So this was a survey published about a decade ago, probably not so dissimilar, maybe a little better nowadays. Obviously, so the question is, if you have symptoms with severe MR, well, it's interesting that still 50% patients did not get any intervention. And then based on your age, of course, as you get older, we don't want to touch patients, even though they're sicker. And then, of course, more comorbidities, again, we don't want to operate because they're sicker. And then if we look at their ejection fraction, again, very similar, ejection fraction goes down, we don't want to operate. So not a lot of options for our patients.
What's the truth, damn it?
I'm afraid, all right? You want to hear me say it? You want to break me down? All right, I'm afraid. For the first time in my life, I'm afraid.
I'm afraid too. There's nothing wrong with being afraid.
There is, for me, there is.
Why, you're human, aren't you?
So a lot of people.
That's Eric and Mark before episodes.
So it's a beast, and it's growing, and of course there's going to be a lot more patients coming our ways with MR with not a lot of options, so surgical options. So why are they not falling from the skies though for transcatheter mitral valve replacement? Like, why aren't we seeing more referrals, for instance? So I think, first of all, pharmacotherapy works in a lot of patients, and a lot of our patients are not symptomatic. I think there are a lot of concerns about the safety of the technology. I think we're concerned about the efficacy of the technology, and we're also quite happy with the clip results, as Anita had already shown today. And of course, we think the prognosis is determined by their LV, and we're getting them at end stage left ventricular dysfunction. Patients are too high risk. The other thing is also the patients are sometimes they're younger than our TAVI or AS population, right? The average age of someone with severe MR is about 10 or 15 years younger than the average age of severe AS. So we also think about the longevity of the disease, right? Longevity of their life. And of course, the other thing is it's very easy to target AS patients with a therapy because the endpoint is death. In our mind, we need to. It makes more sense for us to try and fix something if we can because we're saving their lives. We're versus MR, we're taught to think that it's really we're dealing with symptom management, despite some of the data I've already shown you already. So the techniques that are out there right now, we talk about mitral clip, we talk about other techniques such as indirect annuloplasty, chordal implantation, LV remodeling therapies, and of course transcatheter mitral valve replacement. So this is a cinching device, for instance, to cinch the AP diameter of the mitral valve. This was called AccuCinch, which actually is not readily being used anymore. This was in an ovine model. I'm going to skip some of these slides in terms of the clip, but the bottom line is as Anita had mentioned, the clip has really come a long way in the last 7 to 10 years, reducing hospitalizations for heart failure, and now that number is actually over 40,000 clips worldwide, and so not only has the success of the procedure increased with implant rates of 96%, the long-term results so far have been quite good as well. And so actually it has a class 2B indication for patients with degenerative MR. Of course, most of the patients we assess are functional MR, but we're doing cases with functional MR, but they've not been necessarily approved. Other mitral valve repair technologies that we have seen out there, this is the indirect annuloplasty with cardiac dimensions. So you can see there's a distal and proximal anchor, and this is from an IJ approach. And essentially, you're bringing the AP diameter together, and again, just deploying your distal and proximal anchors. And this has been used in a number of cases, but of course, a small number of cases worldwide. You worry about, again, the circumflex artery. Other repair devices, there's direct annuloplasty with Valtech Cardio, which I think you probably all know was bought by Edwards for hundreds of millions of dollars. So they're going to probably go forward with this, obviously with a trial. And this is a direct annuloplasty, which is a transeptal transfemoral approach where they deliver essentially a corkscrew anchor and deliver an annuloplasty ring percutaneously. Certainly has promise, and we'll see what happens. Again, this will likely come to a center near you if you're doing mitral valve trials. So the question is, what are we going to do with transcatheter mitral valve replacement technology? Well, you can't hear it, but it's essentially crickets because it's a tough nut to crack. And we've been working on this our company's been working on this for about 10 to 15 years. I remember as a fellow, or even before then, going to talks, and we're still having similar discussions nowadays. And there are my crickets. So it's a very hostile environment, and I mean, Wendy's mentioned this already before, and Simran's mentioned it as well. And it's really the LVOT aorto continuity angle is a very difficult area to traverse and to deal with these technologies, because they're quite big. Obviously, the valves are quite big, and you need a big valve to obviously secure it into the mitral annulus. So I guess the question I have for the audience is, do you feel comfortable recommending transcatheter mitral valve replacement to your patients as part of a trial over medical therapy, based on what you know about the devices out there right now? I guess if the patients have no other options, I understand that, but I mean, and the other question I have, if you were a clip center, would you offer a clip to functional MR before considering a transcatheter mitral valve replacement trial for your patient, if not a trial requirement? Now, I assume that most places who see, at least the trial that we're involved in, actually was not a requirement to look at clip before you considered transcatheter mitral valve replacement. So I thought that was interesting. So not all the trials that are being done are actually making sure it's a exclusion criteria. So the potential benefits, so obviously you reduce the MR to a similar extent as surgery. You potentially could reduce the procedural risk compared to surgery. And we say it's potentially more straightforward than the repair, but on the other hand, as Anita just said, we're getting a 30 to 40 minute clip time. The potential disadvantages, of course, is you reduce the MR to nothing in functional MR. And so you get rid of that afterload, and patients obviously can't handle that, and they have very poor outcomes. Potential disadvantage of paravalvular leaks and associated complications of that. Valve thrombosis is a big issue, and these patients will need to be on oral anticoagulation for the rest of their life. And of course, LVOT obstruction. So the issues, as I just mentioned, we're dealing with valve position in terms of access routes. We're dealing with complex anatomy, and the idea is to try to attempt to preserve the subvalvular apparatus. It's definitely a dynamic environment and more complicated than just TAVI. You need to try and avoid LVOT obstruction, occlude circumflex vessels, compress the coronary sinus, cause conduction disturbances, avoid paravalvular leak, and large valve sizes. So these are all engineering issues that we have not overcome yet. And so, of course, now we pretty much perform them in valve, as Simran said, either with the sapien valve or in kids, the Melody valve. And so Simran's already mentioned this, where we can do this, of course, in a valve for severe MR. This is obviously not a new technology, but for TCMVR and MAC using sapien balloon expandable valve. This was just recently published. There were 30 centers involved, 64 patients, STS score 14%. They used 95% sapien valves, and 94% of the patients had MS. Normal EF, and you can see the access point was either TA or TS, with a small percentage having a trans-HO access. And what they showed was a technical success of 72%, but the problem was the 30-day all-cause mortality was 30%. But interestingly, there were no reported annular ruptures, which is interesting. The complication rate and 30-day mortality rate was similar with all three access issues. This was a study also that was recently published on the Tendyne valve, which is one of the transcatheter valve technologies, and it's a self-expanding nitinol frame. And this was a transapical route with 8 sites, 30 patients were enrolled, and the STS score here was 7%. And most of the patients actually had an EF greater than 30%, which is key, I think, to the success of these technologies. And you can see most of them had functional MR as well. Procedural and 30-day outcome, so actually 28 out of 30 successful implants and only 1 LVOT obstruction, with 1 non-cardiac death, no strokes, no valve embolization, 1 valve leaflet thrombosis which resolved with anticoagulation, and 1 patient with PVL. of course, the EF actually decreased, which was significant from 47 to 41%, which is not completely surprising, given, again, the afterload that now the ventricle has to deal with. But this was actually promising in terms of the outcomes. Another valve that's being evaluated is a CardiaQ valve, which is a bovine pericardium valve, again, self-expanding and repositionable. They're all repositionable. The nice thing about CardiaQ potentially is that its transseptal approach, as is another valve in the armamentarium of Caisson, which is another valve being investigated. Those are the two valves I understand right now who have been inserted in humans that are transseptal. And there's been only 20 cases worldwide, and this is actually being evaluated in, again, an early feasibility trial. And actually, they had to hold the trial in February because of complications and a high mortality rate. There was about a 50 to 70% mortality rate in the first number of cases. And they weren't necessarily related to the valve, actually. They were actually even related to just bringing the valve into the left ventricle, which can be quite complicated sometimes. So a number of things you need to consider, though, for these patients, including not just their LVOT angles, but also their LA height, which is a major issue for these valves because these valves all live supraannular. And this is a valve going in transseptal. You can see it's a monster. You can see how big it is, how it sits supraannular with the transseptal technique. And there it is on CT scan. Now, of course, if you have a massive left atrium, it works well. Of course, the thing you're concerned about, again, is clot forming on the leaflets. And so these patients are all on anticoagulation afterwards. So, slow sprint to the finish. There's been less than 300 procedures to date, and that's over a lot of years. There's now over 30 companies in preclinical development, and really there's just 4 or 5 types of valves in first-in-human implants in early feasibility trials.
Ready? Equipment is aseptic and ready for use. You sure we're ready?
Having doubts?
It's to be expected.
Not from me.
How can you be so certain?
So I think we're still in a very experimental phase here. It is a cautionary tale. And think about these technologies. I think actually having too many companies trying to win the race is a problem here, to tell you the truth. And I think actually it's hindering our ability to properly investigate these patients. But there's not much we can do about that now. We're kind of we're pawns here a bit and trying to help out the companies deliver their technologies. But I think that is a major issue going forward with, like I said, over 30 companies trying to reach the finish line. And I'll end there.